Hi friends, welcome to the cardiology practical exam classes. Basically, I would like to tell you all the tips and tricks of practical examination first to give you an idea how the practical exam will be conducted, and then to introduce about cardiology, the interesting and impressive things about cardiology as a subject. Okay, so before going further, first of all, I would like to thank my Lord Almighty, my family members, my parents, my teachers, my patients, and all the friends who had motivated me in pursuing medicine. So basically, before going further, I would like to tell you an incident. Basically, the one of my friends went to attend a microbiology viva to HOD ma'am. She asked a question after showing a plate, a culture plate. What is this? And he answered, it is a chocolate agar. And then she said, good. And what is it made of? It is made of chocolate. Without expressing anything, the teacher asked whether it is homemade or dairy milk. So this is how practical exam will be. A lot of ragging, a lot of fun, and these are routine. And you should be able enough to answer what are being commonly asked. What are the basic requisites, basic expectations from your teacher. So the first question which I'd like to put you is, what are the best books, or which of the following is best for practical medicine? Best book for practical medicine. Yeah. Option 1, is it MacLeod? Yes, MacLeod. Option 2, is it Hutchison? Option 3, is it Alagappan? Option 4, is it Kundu? Yes. So what is the best book? The best book is not all these things. It is your teacher's notes, your teacher's classes. Remember that, it's very, very important, because your teacher is the one who is going to sit in the exam and assess you. Even in the final exam, there will be two examiners, one external and one from internal, one from your college, one from any other college, and your teacher will expect the things which he or she taught you. So it is very important that you should take proper notes and properly attend all the classes, actively be active, show interest, so that you learn all the things which your teacher teaches in the classes. Okay, that is very, very, very important. Don't think that you can master medicine by reading books. It is very, very important. Okay, and regarding the best books in medicine, Bible of Medicine is Harrison's, and the Bible of Cardiology is Brownwald. But don't read Brownwald and tell that these are the points are very, very important, and this is the best point, this is the best book, like that, because basically your teacher is a physician and who has completed an MD General Medicine, will be expecting points from Harrison's. So if you have a lot of time, if you want to master things, you can read Harrison's first, and after reading the basic books, especially MacLeod or any of these books, can go ahead. If you are very interested, you want to learn further, then there are some books which I would like to suggest you. Okay, basically for neuro, there is a book called Bickerstaff. Okay, and for RS, respiratory, there is a book called Vakil and Golwala. Okay, and CVS, there is a book called Perloff. So if you are thorough with the basic books, basic stuff, you want to go further, if you are interested to learn more, then you can, I'll suggest you to read these books: Neuro, Bickerstaff, Respiratory System, Vakil and Golwala, and CVS, it is Perloff. And so first of all, the most important thing on your exam day is good prayer, to submit everything to God, to tell that everything should happen well, expect the good things from Him, and then go ahead. Because ultimately the examiner can ask questions anywhere within your Hutchison, Harrison, or in your notes, anywhere. The examiner has a lot of experience. Basically they'll be practicing medicine every day, and so they can ask questions from anywhere, and at least you should know something so that you'll be able to pass. Yes, and of course passing is not important, you have to score well, that I agree, but sometimes what happens is in your exams you'll be so much stressed that you will forget everything will go blank. So that should not happen. So be confident, pray well, and then go for the exams. The next most important thing I would like to suggest is a fluent case presentation. Basically, anyone can write a case sheet. Even a person who is copying his friend can also write a case sheet. But the fluent case presentation will tell that you have read properly, you have presented a lot of cases in your past. So these are the things which the examiner will be conveyed. So he can give you good marks. And next is a neat case sheet. Okay, so you can like your plus 2 exam, you can put margins, underlines. Okay, but this remember, this is time management is very important, because you'll be given only 45 minutes for a long case. Okay, and around 15 minutes for a short case presentation. Short case presentation will be only of examination, and long case will be your history taking and examination. So time management is very important, but at the same time, write a neat case sheet and give only appropriate answers. For example, like if you are asked what are the causes of ventricular septal defect, you are telling that Edwards syndrome. Okay. As soon as he asks, you are telling Edwards syndrome. No, that should not be the answer. Okay, basically the answer should be from basics to hi-fi things. Okay, the common things to the uncommon things. Okay, so the commoner things are the most likely that you will see these things first. For example, a patient with MD, mid diastolic murmur, is more likely to have a mitral stenosis than an atrial myxoma. Okay, so those things are expected by the examiners, and you should answer those first. And of course, you should never under answer, that will lead to dissatisfaction. They will not be like, okay, if for example he's asking hemoptysis, what are the causes? You are telling tuberculosis. Next, he is telling only tuberculosis. That is not sufficient. Okay, you should tell other DDs as well. Okay, tuberculosis is very common, agreed, but bronchiectasis can also cause hemoptysis. There are a lot of other n number of answers which you can give for hemoptysis differential diagnosis that the examiner will expect. Okay, and another thing which I would like to stress is the apt answer. For example, one of my friends was asked, you have elicited hyperreflexia in this patient, a central nervous case. He had presented well, and he was asked, you have elicited hyperreflexia. What will be the next step to be examined? And that is, the answer is clonus. Okay. But he told like, sir, hyperreflexia, I would like to think in terms of and lesion. That is not the answer. What is he asking? What next will you elicit? That is clonus. You should look for clonus. Okay, give always an apt answer to the point. And remember, the most common cause will be the first and best differential diagnosis. See, hemoptysis differential is being asked, and the best answer should be tuberculosis. Okay, rather than a lung carcinoma or a good pasture syndrome. Basically a vasculitis. Tuberculosis is very common in India. A lot of people are dying because of tuberculosis. A lot of new cases are coming in tuberculosis, and that should be the best answer, first answer for your examiner. Okay, so make sure that the most common cause will be answered first. And there are some things which you should be thorough with. Whatever conditions are prevailing in large quantities in India, you should be thorough with. For example, as discussed earlier, tuberculosis, ischemic heart diseases, myocardial infarction, cardiac failure, alcohol, all about alcohol consumption and smoking, and these pickle things, the paler icterus cyanosis clubbing, which I will be discussing in detail in a subsequent presentation. This is very important. And vital signs, yes, your pulse, blood pressure, respiratory rate, temperature, all these are very important. Okay, because these things you will ask in almost every case. Apart from this, the common diseases encountered, diabetes, hypertension, thyroid problems. Okay, so these are the things which you are expected to answer well. You are expected to know thoroughly. Okay. And whenever you are asked a differential diagnosis, always try to classify an answer. It's very important. It tells you that you are thinking laterally. Okay, so in medicine, it is always expected that you should think laterally. For example, a patient coming to you with abdomen pain, you should not think in terms of peptic ulcer. Can be due to mesenteric ischemia. It's not sufficient. Basically, you should think in terms of other systems as well. Basically, a cardiac cause of abdomen pain can be a dangerous inferior wall myocardial infarction. Okay, so basically, always you try to classify an answer. You can tell, for example, DDF clubbing. You can tell like respiratory causes like bronchiectasis, emphysema, carcinoma, and cardiovascular causes like cyanotic congenital heart disease. And then infective endocarditis, gastrointestinal causes like ulcerative colitis and Crohn's disease. See, this is the best way. Always classify and answer. Okay, it helps you to recollect lot of points which you have learned. If you classify system wise, for example, cardiovascular cause, respiratory cause, your GI cause, then you can recollect easily. And it also tells the examiner that you have read well, you are thinking laterally, when asked about a particular symptom. For example, right upper quadrant pain. You can tell simply that it can be due to cholecystitis, yes, but can also be due to right heart failure causing an enlarged tender hepatomegaly, tender painful hepatomegaly. Okay, the important cause of a tender painful hepatomegaly is a right heart failure. And never commit the things which you are not confident about, and don't argue with the examiners at any cost, because it's dangerous. Your examiner is very experienced. His age is, almost usually twice your age, and then in that case you are not supposed to argue. Tell that this is the right point, this is given in this book. You cannot say that. You have no rights to say that. Okay, he has a lot of experience, he has seen a lot of patients more than you. Okay, and so always remember that your examiner is always right. Okay, tell okay sir, okay, I will read sir, thank you sir, like that you have to tell and move to the next point. Okay, that is very important. Never argue with your examiners. Okay, and try to present the long case to the set of examiners whom you feel they are very soft and helping. Why? Because this is an option. Sometimes it can happen, you will not be provided an option to go to whichever examiner you like. Sometimes it will not happen, but still, if you are provided an option to choose the examiner, you can go to the set of examiners. You will feel soft and helping. Basically, this information you can get by asking the previous batch students, the students who have given exam the previous day. If you ask them, they will tell like, this examiner is very soft, he was helping, he was teaching so many things, he was motivating. Such kind of examiner, you will also feel like answering. Okay, some examiners will be like very tight. What is that hematosis? Is that clubbing? Like that he will ask. Okay, he will ask you so that he may confuse you as well. Okay, whether he will check whether you are very strong in your answers. So rather than going to such kind of examiners, you can go to an examiner who can help you, who can motivate you, and who would like to take answers from your mouth. Okay, so, and the next point I would like to tell you is write the examiner findings of short case in the paper given. In some examinations, it will be given a small bit of paper will be given, and you can write all the findings in the sequential manner, right from the general examination, the positive findings, inspection positive findings, like that you can write. Okay, always write the findings in legible manner. Sometimes the examiner will collect the paper and see how much you have written, what are the findings you have noted. Most of the times for short case presentation, you are allowed to ask only the history, only the examination asked. You are supposed, in short case, you are supposed to do only the examination. For long case, you can ask questions, whatever history you can collect. But for short case, you are supposed only to examine, not to talk to the patient. Very, very important. If any examiner notes you are talking to a patient, they will definitely create a lot of problems. Okay, it's very important. And look into the internal examiner notes the day before. Very, 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 very important point. Okay, basically, this helps you to score well, score more than others. As I told already, the points which are deep-rooted in your examiner's mind will be taught in the previous classes. For example, Mr. Selva is there, Dr. Selva is there, who is sitting as an examiner. Dr. Selva would have taken a lot of classes to you, and in those classes he would have highlighted certain points. For example, MAN2 test can never be positive in sarcoidosis. MAN2 test positive rules out sarcoidosis. Okay, so these are some classical points which he would have taught you, and in the exams he will always expect those questions, expect those answers from you. Okay, he will always ask those questions which he feels interesting and which he feels very important to know. Okay, so please make sure that you take the notes well, and the day before the examination you will know, of course, which internal is sitting in the exam. You can collect those details. It's possible. So in that case, you can concentrate on those notes, and then you can excel in the exams. And of course, sleep at least 4 to 5 hours the day before exams. So last minute help, basically if you don't know the diagnosis. For example, in our respiratory system, you will be told in short cases, okay, you will be told about which system to examine. It's an RS case or it's a CVS case. So such details they will tell you. So what you can go is, you can try to identify the diagnosis. Of course, RS can be consolidation, fibrosis, cavity. So by mere examination, you can come to a conclusion. Suppose you are not able to reach the conclusion, you can definitely ask. This is a last minute help, of course. So you can ask the residents, someone is staying there, you can ask, sir, I am not able to pick the diagnosis. So sometimes they will help you and help you to understand, help you to arrive at the diagnosis. but make sure you double check the diagnosis. Even if your examiner or even if your the person who is responsible for arranging the cases tells you that this is a case of right pleural effusion, make sure you check, double confirm that before arriving at a diagnosis, before telling it to the examiner. Okay, so this is a last minute option which I am telling you, but make sure that none of your examiners is noticing you. Okay, so the discipline is very very important. Your external appearance, you should wear a good white coat and number badge. And the requisites, basically you should understand how to sequentially examine a patient. For example, you should not put a step straight to the chest and finish off the examination. First of all, you see a general examination, you check vitals, you check for pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema, all these things first. Then you are going to take the patient for examination, for inspection, then you palpate, then you percuss, then auscultate. Okay, so these sequential steps are very very important, because sometimes the examiner who is going to ask questions will be watching from the distance, okay, how you are examining. Okay, that gives an impression about you. So very very important that you do all the things sequentially. Okay, and the qualities which I like to enforce are basically orderly, be orderly and alert, and be silent. Okay, so those things will impress the examiners. And this is the set of things which the MacLeod has given, but not all things are important. Of course, you should need a stethoscope, pen torch, tape, ophthalmoscope, otoscope, no need. Sphygmomanometer, yes, tendon hammer, tuning fork, cotton wool, and spatula, thermometer, okay, magnifying glass, no need. Weighing scale will be available most of the times in the ward, okay, and PPE, this is given but not necessary, and blood samples and this is also not necessary. So other things are important. There are charts which are available in MMC cooperative store, neuro charts. Okay, all the neuro CNS kit will be available in Stanley Medical College cooperative store. Okay, so you can go to MMC and Stanley Medical College cooperative store. You can ask for the neuro charts. They will give you a set of things. Stanley will give you the CNS examination kit, Paka. And so if you can go there, you can definitely go and purchase it and keep. It is very good for having during the examination. So examining the patient, basically long case, be bold and confident. Thorough examination is very very important, and time management is equally important. Okay, and this is the golden words. Stand on the right side of the patient always. Okay, never ever think of standing on the left side unless there are specific indications. For example, some examination you will not be able to do from the right side of the patient. You have to go to the left side of the patient and examine. And for short case, never talk to the patient, okay, except for asking him to cooperate for examination. For example, you can tell him that please lie down, okay, please get up. Except for these words, you are not supposed to talk to him, not supposed to ask the history. Okay, so make sure that you follow the things correctly. Okay, so remember once again, your examiner will be watching from a distance. Be careful, be polite, be confident, okay, and examine in a sequential manner. Before going further into the class, into the practical class, I would like to reinforce this point, because whatever I am teaching is going to be a theory teaching. Not I'm going to not stand at the bedside of a patient and show you the videos how I am examining. So this is not sufficient. Okay, what I'm going to do is, the idea of this class is to help you to understand what are the things which your examiner likes to ask from you, what are the things which are very important, okay, and what are the common diagnoses which you have in your practical exams. Okay, and to create interest, I have put some 12 case scenarios in the subsequent slides, which you can try to answer, which you can help you to understand what are the common symptoms which we encounter in the cardiovascular system. So this is a famous quote by Dr. William Osler: "He who studies medicine without books sails an uncharted sea, but he who studies medicine without patience does not go to sea at all." So standing at the bedside with your teacher, examining the patient thoroughly is very very important than reading the books. Okay, and your examiner's words are golden words. You should be aware, and you should be thorough with those things what your examiner asks during the classes. Okay, and these questions will be repeated in your exams as well. So with this, I would like to go into the cardiology per se. What makes cardiology special? So this is by Dr. Chidambaram sir, who used to say these statements often. Okay, basically life begins when the heart starts beating, life ends when the heart stops beating. All organs depend on heart for functioning. Anyone can live with some organs not functioning, but none can live with heart not functioning. And this heart works non-stop without rest, even when it is injured. So these are the special things about our cardiology. Okay, so the first organ to function, even in your USG, you can see in the pregnant lady, the first organ to start functioning is your visualize is heart. Okay, so a lot of special things about cardiology, and these are the things which makes it very special, very interesting. And if you are thorough with cardiology, you can manage a lot of cases in your day-to-day life, practical life. So this is a case scenario 1. Mr. X, 56-year-old gentleman, presented with complaints of exertional chest pain and retrosternal, it's radiating to jaw whenever he walks fast. Okay, and this was associated with dyspnea. There is no associated syncope or palpitation. Patient feels better after taking rest for 5 minutes. He was diabetic for the past 10 years and hypertensive for the past 4 years. There was no history of smoking or alcohol consumption in the past. What is the probable diagnosis? Yes, what can be the probable diagnosis? Whenever he walks fast, the patient is having chest pain, which is radiating to jaw. Okay, and this is associated with dyspnea as well. Basically, this is the typical history when a patient is having ischemic heart disease. Okay, ischemic heart disease. So normally there is a left main and LCX will be there, and one LAD will be there, and here another RCA will be there. Right coronary artery, left coronary artery, and left circumflex artery. This is the left main artery. Okay, so when there is a plaque which is impairing the blood supply to the heart, when there is exertion, when the workload of the heart increases, the body will not be able to meet the metabolic demands of the heart. That produces your chest pain. Ischemia will produce chest pain, and when the patient takes rest, it will settle down. These are the classical symptoms of angina pectoris. Okay, so chest pain on exertion, relieved by it is retrosternal, relieved by rest or nitrates. These are the 3 points which suggest that it is an angina. Okay, this classically happens in ischemic heart disease. Another differential diagnosis where exertional angina, syncope and chest pain. Angina, syncope and dyspnea. Sorry, it's not chest pain. Exertional angina, exertional dyspnea and exertional syncope occurs together is aortic stenosis. This is also an important diagnosis you should have in your mind. Okay, shall we move to the next case scenario? Mr. Y, a 40-year-old gentleman, presented with complaints of chest pain, retrosternal, which is very heavy, increasing in intensity, radiating the right shoulder for the past 4 hours duration. This was associated with sweating. There was no associated dyspnea, syncope or palpitation. There was no relieving factors. He had a smoking history of 10 pack years. He was not a diabetic or hypertensive. So what is the probable diagnosis? The same symptoms which we saw in the earlier case has occurred here, but here it is persistent. There is no relieving factors. There is no relief at all. It is continuously, it is increasing intensity. So in that case, can be a case of acute coronary syndrome. What is acute coronary syndrome? Acute coronary syndrome includes 3 different diagnoses. Yes, one is your STEMI, that is ST, elevation myocardial infarction. Another is a NST-ACS, that is non-ST elevation myocardial infarction. Another is an unstable angina. So these are 3 different diagnoses which will come under this heading. Okay, the acute coronary syndrome, and this which can be proved by the ECG and cardiac enzymes. After taking an ECG and cardiac enzyme, ECG showing ST elevation and cardiac enzymes are positive, the diagnosis is STEMI, STEMI, ST elevation MI. And if the ECG is showing minor changes and the enzymes are positive, it is non-ST elevation MI. And if the ECG is showing not significant changes and the enzymes are also negative, it's not positive. Okay, in that case the diagnosis is unstable angina. Okay, ECG ST elevation plus enzyme positive, it is ST elevation MI. ECG changes present, not ST elevation, with cardiac enzymes positive, it is NSTEMI. If there is no significant ECG changes and no enzyme positivity, then it can be due to unstable angina. And remember, the classical symptom which the patient will have is a fear of impending death, which is also called as Angor anemia. The fear of impending death, which is also called as Angor anemia. Mr. Z, 46-year-old gentleman, presented with acute onset dyspnea with chest discomfort for the past 4 hours duration. Dyspnea with chest discomfort. Okay, associated with sweating. There was no associated syncope or palpitation. Patient feels better with sitting upright position. He had chronic kidney disease for the past 5 years. He was diabetic and hypertensive for the past 10 years. Okay, so he was not a smoker. So what is the probable diagnosis? This patient can be having an acute left heart failure, which is also called as acute pulmonary edema. Acute pulmonary edema. Okay, basically this chronic kidney patients can have this, and kidney disease, chronic kidney disease basically can lead to accelerated atherosclerosis. Okay, and the patient having diabetes and hypertension can also have a coronary artery disease, which will lead to failure. The most important thing to be ruled out in a patient with acute pulmonary edema or acute left heart failure is a myocardial infarction. Okay. So fourth case scenario, Mrs. P, 40-year-old lady, presented with dyspnea and exhaustion NYHC class 3 for the past 1 day duration. There is no chest pain, no syncope, no palpitation. She had right leg discomfort for the past 1 week duration. Not a diabetic, not hypertensive. She takes oral contraceptive pills. So as soon as you read these words, you should have come to a diagnosis. There is no family history of CAD as well. The probable diagnosis is acute pulmonary embolism. Acute pulmonary embolism. See, pulmonary embolism, we think that it is an acute onset dyspnea, like 1 hour duration. Not like that. Massive pulmonary embolism can present like that, but massive pulmonary embolism constitutes a lesser incidence. Basically, has a lesser incidence than other types of pulmonary embolism. So, can present like this also. Okay, and this DVT history is the electric discomfort is there. OCP can be a trigger. Okay. And case scenario 5, Mrs. Q, 50-year-old lady, presented with complaints of palpitation for the past 3 years duration. She age is 50 years. There was no history of chest pain, syncope or dyspnea. There was no history of exertional angina or dyspnea in the past. Okay, and she was a known case of rheumatic heart disease for the past 20 years on regular medication. So what is the probable diagnosis? Palpitation. Palpitation in a case of rheumatic heart disease is most likely due to atrial fibrillation. Okay, atrial fibrillation. Known case of rheumatic heart disease, 50-year-old lady, palpitation for 3 years, sudden onset palpitation can be due to atrial fibrillation. Okay. And sixth case scenario, Mrs. S, 28-year-old lady, presented with complaints of palpitation for the past 3 months duration, usually sudden in onset and disappears after 1 hour and is associated with fluttering sensation in the neck. After the palpitation disappears, the patient passes urine and is able to do all the activities as usual. Passes lot of urine, and as soon as the palpitation disappears, the patient passes lot of urine. Okay, and there was no history of chest pain, syncope or dyspnea in the past, and there was no other comorbidities. What is the probable diagnosis? Intermittent episodes of palpitation in a 28 lady with no previous comorbidities, no coronary artery disease, then the possible likely diagnosis is supraventricular tachycardia. Supraventricular tachycardia. Okay, basically ECG will show narrow complex tachycardia, narrow complex. Okay, because it follows a normal conduction pathway, the complexes will be narrow complex. And the treatment of choice is adenosine. Okay, adenosine is the treatment of choice. Okay. And seventh case scenario, Mr. L, a 60-year-old gentleman, presented with complaints of acute severe chest pain and palpitation for 2 hours duration. Severe chest pain, palpitation. This is associated with dyspnea as well. There is no history of syncope. Diabetic hypertension for the past 20 years on regular medications. There was no history of similar episodes in the past. On examination, pulses were feeble. BP was not recordable. Cardiac monitor shows heart rate of 180 per minute. Bizarre QRS complexes. So 60 years, severe chest pain palpitation for 2 hours duration. Okay, with the chest pain. Remember, palpitation without chest pain in a young lady may be due to an SVT. In one case of rheumatic heart disease can be due to atrial fibrillation. But 60-year-old gentleman with chest pain, there is no previous episodes in the past, and cardiac monitor showing 180 per minute with bizarre wide QRS complexes. Then the diagnosis is ventricular tachycardia. Remember, ventricular tachycardia can be diagnosed with broad complex tachycardia. Basically, broad complex, the QRS duration more than 120 millisecond. QRS indicates ventricular depolarization. The QRS will be normally narrow because it follows the normal conduction pathway. His bundle Purkinje fibers, okay, bundle of his and Purkinje fibers, they are the normal conduction pathway. But in ventricular tachycardia, what happens is there will be ectopic origin of focus from the ventricle, and that will cause muscle to muscle conduction rather than flowing through the normal conduction pathway. There will be muscle to muscle conduction that will lead to widening of the QRS complexes. Okay, so and this is basically a VT, and the treatment of choice is defibrillation. Okay, so if the patient suddenly collapses, if the patient is coming to the casualty and you are seeing the patient coming inside, suddenly collapses, becomes unconscious, then, and if you are checking the pulse is not palpable, especially in this scenario, carotid should be felt. If it is not palpable, then you should start immediately CPR, your cardiopulmonary resuscitation, according to the recent ACLS guidelines, Advanced Cardiac Life Support by American Heart Association. There are a lot of programs going through, and you can definitely attend one and benefit. Okay, and there are 5H and 5T which should be considered in a patient with cardiac arrest: hypovolemia, hypoxia, hypo or hyperkalemia, acidosis, hypoglycemia. If child, this hypothermia can also be a reason. And the 5 T's are toxin, trauma, tension pneumothorax, cardiac tamponade, and coronary or pulmonary thrombosis. So, when a patient is collapsing, having a sudden cardiac arrest, and then the possible 5 H's and 5 T's are discussed here: hypoxia, hypovolemia, hypo or hyperkalemia, hydrogen ion, hypoglycemia, hypothermia of a child, toxin, trauma, tension pneumothorax, tamponade, and thrombosis, which can be due to a coronary thrombosis, that is your acute myocardial infarction, or a pulmonary thrombosis, that is your pulmonary embolism. Okay, coming to the 8th case scenario, Mr. B, 80-year-old gentleman, presented with complaints of dyspnea and exertion NOH class 3 for the past 1 week duration. There was associated syncope on exertion, no chest pain or palpitation. On examination, all the peripheral pulses are palpable, but pulse rate was only 36 per minute. There was no history of diabetes or hypertension. He neither smokes nor consumes alcohol. What is the probable diagnosis? The probable diagnosis here is, see, heart rate is very low. There is history of syncope. Okay, and no risk factors are there. Age is a risk factor here, advanced age. So that can be due to a complete heart block. Okay, basically what happens is there can be degenerative process which is going on in the heart, in your body, when age advances. And in the conduction system, if it happens, that can lead to complete heart block. Okay, the atrium will have its own rate, atrial rate, and the ventricle will have its own rate. Both will not coordinate or coincide with each other. They will not be contracting synchronously because of this, and that will lead to complete heart block, and that will manifest with this dyspnea on exertion and syncope, especially syncope on exertion. And the treatment of choice is permanent pacemaker implantation if there is degenerative heart block. Okay, and this is case scenario 9. Mrs. M, 25-year-old lady, tall lady, presented with palpitation, lightheadedness on and off for the past 4 years duration. There was no history of chest pain, syncope or dyspnea. On auscultation, the physician elicited sound during the mid to late systole, which was different from the normal heart sounds. So, what is the probable diagnosis? It can be due to a mitral valve prolapse syndrome. Mitral valve prolapse syndrome. This palpitation, lightheadedness can be there. Okay, it is also called as Barlow syndrome. Barlow syndrome, systolic click murmur syndrome. Okay, there will be a late systolic murmur. Okay, the classical murmur heard is late systolic murmur. It's also called as mitral valve prolapse syndrome, Barlow syndrome, floppy valve syndrome, or billowing mitral leaflet syndrome. These are the various names which can be given for your mitral valve prolapse syndrome. Okay, there can be a non-ejection click which can be heard during auscultation. Non-ejection click. Okay, ejection click is when there is blood flow through the aorta or pulmonary artery is obstructed because of a stenosis. The valve opens suddenly with the click. That is called your ejection click. Here in the MVPS, mitral valve prolapse syndrome, the click happens, but it's not during the ejection phase. Basically, the ejection should happen in the aorta via the aorta during the systole. But this is called as non-ejection click. Okay, mitral valve prolapse syndrome. Case scenario 10. Mrs. O, 45-year-old lady, presented with complaints of fever and weight loss for past 5 months duration. Fever was intermittent, no history of cough with expectoration, sore throat, burning, micturition, or any other focal symptoms. Auscultation, the physician identified a mid-diastolic murmur, also a sound in heart which varies with posture of the heart. Okay, so what is the probable diagnosis? The diagnosis is atrial myxoma. Atrial myxoma. So basically a benign tumor only. It arises usually from the intraatrial septum. It can also produce a mid-diastolic murmur. Okay, so mid-diastolic murmur in a patient with fever, long duration of fever. The first most important cause which you should remember is infective endocarditis. Okay, a patient with rheumatic heart disease having fever, you can diagnose infective endocarditis easily. Otherwise, fever with a mid-diastolic murmur, you can think of atrial myxoma as well. Okay, this is also another differential diagnosis for your fever for longer duration and weight loss. Okay, and coronary complex, there is a few features which are occurs together like a syndrome. It's also called as coronary complex, which includes myxomas, lentiginous, pigmented nevi, and endocrine overactivity. Okay, these are the triad of features which can cause which encompasses the coronary complex. CARNEY, coronary complex. Okay, And other syndromes associated with the atrial myxoma are name and lamb. NAME, you can read later, LAMB. Okay, so these are the named syndromes which can occur with myxomas. Okay. So case scenario 11, Mr. C, 70-year-old gentleman presented with complaints of acute onset chest pain radiating to back and abdomen, tearing in nature. That's all, this word is enough. Tearing pain, migrating pain. Okay, then you can think of this diagnosis. We'll move ahead with the case scenario. There was no history of dyspnea, syncope or palpitation. He was a known case of hypertension for the past 10 years, smoker with 30 pack years history. On examination, all the peripheral pulses were palpable. His BP was right upper limb was 150/90, left upper limb was 90/70. See, there is radial delay. There is difference of BP between the two upper limbs. Usually, it should not exceed more than 15 mm of mercury, systolic BP. Difference between the right and left upper limbs. But here there is gross difference. Okay, then the diagnosis is clear. It is aortic dissection. Aortic dissection. What happens is suddenly there will be a tear in the intima of the artery. Okay, and the blood will enter into the intima, through the intima into the media it will enter, so that the intima and media will get separated because of the blood. Okay, so that is called aortic dissection, which can happen in old age, hypertensive patient with smoking history. These are the risk factors which can produce your aortic dissection. Okay, and this is the last case scenario which I like to discuss. 25-year-old female, lean individual, presented with complaints of dyspnea and exertion, NOHA class 2 for the past 2 years, associated with palpitation and exertion. There is no chest pain or no syncope. There was no comorbidities, no history of rheumatic fever in the past. Auscultation diagnosis picked up. What is the probable diagnosis? So, to lean individual, 25-year-old lady, can be due to number 1, ASD. Okay, dyspnea and exertion, NOHA class 2 with palpitation and exertion. The most important diagnosis to be considered, AST. Second, it can be due to mitral stenosis also. Mitral stenosis also. See, rheumatic fever need not be present in all patients of mitral stenosis. In India, the most common etiology for mitral stenosis is rheumatic etiology, rheumatic fever. But sometimes the history may not be there. The patient would have presented, had a fever, mild subclinical illness, but later developed a rheumatic heart disease. So, basically, lean individual, 25-year-old lean, then you can definitely consider these two probable diagnoses. One is an ASD. In ASD, there can be wide fixed split. The S2 split, A2P2 split will be wide and fixed in ASD. Whereas MS, there can be a mid-diastolic murmur. Okay, so these are the case scenarios I would like to discuss. And with this, we would like to recollect the cardinal symptoms of cardiovascular system. So number 1 is chest pain. We had seen almost all cases have chest pain, dyspnea, palpitation, syncope or pre-syncope, and pedal edema. Okay, these are the cardinal symptoms of CVS. I hope this presentation would have been of benefit to you. Okay, you would have understood how a long case should be present, 45 minutes duration, history, examination in a sequential way. Okay, and short case, you're just supposed to examine the patient well without talking to the patient. And there are some important tips. Basically, read your professor's notes well. Your professor is your best book. Okay, first ask them, make sure whatever they like, whatever they teach, write in your notes, okay, and read it properly. Then you can go ahead with other books. Okay, and the most important things which I would like to highlight and recall again is properly telling the most common diseases in India, or most common cause of that particular differential diagnosis should be highlighted first. For example, hemoptysis, tell tuberculosis, okay, rather than lung carcinoma or vasculitis. Okay, and always try to classify and answer. For a patient, if you are, we discussed, right, clubbing, then you can think of CVS causes, RS causes, then abdominal causes. So like that, you classify and explain them, then it will be of very useful, and the exam will be very much impressed, and which will help you to get more marks. So with this, we have come to the end of the presentation. So for any doubts or feedback, you can mail me or WhatsApp me. Okay, right. We see you in next presentation. Thank you one and all.